There are multiple studies which has essentially established that physiological assessment as part of PCI is before PCI is well established. So we aim for functional revascularization. Treat the ischemic lesions and leave aside the ones which are non-ischemic. We've also seen this slide. So if you defer a non-ischemic lesion, even after 15 years, you're likely to do better than if you required a stent in the first place. So even a more recent study on the syntax 2 shows the same. So in short, we now also know it's safe to defer lesions. So physiology before PCI is done and dusted as far as the data goes. If you just rewind a bit, so this is the COURAGE study. Again, it's been shown once by one of the speakers. And what it shows is, if you look into angina-free survival, even in the PCI arm, 20 to 30% of the patients have residual angina. And this is across whichever PCI versus OMT study you look into. So the question is, why do we have residual angina in these patients when they already have been revascularized? So this is not a comprehensive list, but few causes. One, we have done PCI to the wrong vessel. It does happen. It's happened to all of us. We have done a PCI, it's inadequate. And this happens much more than we probably realize. There's microvascular angina, which is the next speaker's talk. And maybe the patient had microvascular angina along with or instead of epicardial ischemia. And finally, there is a cohort of patients where we diagnose significant coronary disease, but the symptoms were never angina, so they don't get better as far as the symptoms go. So my remit is to convince you that at least in these 2 out of these 4 conditions, maybe if we routinely do post-PCI physiology, we can at least identify, treat, and hopefully improve these patients. So does post-PCI physiology make a difference? There's been a multitude of studies from the FFR era. So this is, you can probably find 20, 25 if you wish to. And what they always have consistently shown is 20 to 30% of the patient leave the lab with an ischemic vessel, the vessel we have treated. Does it make a difference to the final outcomes? Well, it does. Even in 2002, what it showed us is if you have a FFR of less than 0.9 post-PCI, you're more likely to do worse than if you have a FFR of more than 0.9. And this is one of the earliest studies based on which we aim for a post-PCI FFR of greater than 0.9. And there are a multitude of studies. For the time's sake, I'm not showing all of them. But these were all retrospective studies. But what it helped us is to look into possible causes why we might leave a vessel ischemic even after a PCI. And the first study which looked into it prospectively was the DEFINE PCI study. Okay, and the purpose of the study is to work out what percentage of people remain ischemic and why they've remained ischemic. And what they found in the acute phase is a quarter of the patients left the lab with a positive IFR when the operator thought they had done a good job. And out of those, nearly 4/5 essentially we missed a focal lesion. By focal we mean less than 15 millimeters. So if we could identify these patients and treat them optimally, we can reduce the number of patients leaving the lab with ischemia from 24 to potentially 5%. Okay, so in this particular study, did it make a difference like the FFR studies? So if you then compared the patients who had an IFR of more than 0.95, we found that those cohort of patients did very well, or much better, compared to the ones which had an IFR of less than 0.95. So just let's look some real life cases to see whether it makes a difference to, I hope this plays. Okay. Okay, so we have a problem with the videos not playing, which it did when I tried them. Anyway, let's move on. So this patient essentially had a diffuse disease in the LAD and had a blocked circumflex. And when you IFR'd the LAD and the diagonal, what we had was a positive IFR in both the LAD and the diagonal. And when you went forward and treated the circumflex CTO, which is straightforward wire escalation technique, and you repeated the coronary physiology in this particular patient, what we found is the IFR of the circumflex was very satisfactory post-PCI. But what we also found is the IFR of the diagonal and the LAD were now negative. So what a post-PCI IFR of the donor vessel allowed us to do was identify that the patient had functionally 2-vessel coronary artery disease rather than 3-vessel coronary artery disease. So the next patient, this place. Okay, so this patient is a bit more elderly with quite advanced CKD, with advanced heart failure, and presented with an end-stem. And what it shows is, on the left, it shows a long length of disease in the mid-LAD, but also if we could spot that there's not much flushback in the ostium of the left main stem. And obviously the right is blocked at the ostium, so it's being fed back from the left system. So we imaged it, prepped the vessel accordingly, and put a long stent in the LAD, which we thought should do a good job. We post-dilated the stent to the size we felt was appropriate according to the IVUS. But we repeated the physiology, and it was nowhere close to where we would want it. So very ischemic, despite a long length of stent in the LAD to cover all the lesions. So we went back and re-imaged it, and based on that, what we did was there was opportunity to further optimize the stent in the mid and the distal part. And we re-IFR'd it. It's better, it's still ischemic. So you're not going to have an IFR of 0.79 just being optimized with post-dilatation, but it does make it better by a reasonable number, as we can see. And what we can see here is the biggest jump in the IFR pullback is essentially the ostium of the left main stem. So what we did, we treated the ostium of the left main stem, and we came back and we re-IFR'd it, and it was 0.93. So still not 0.95, but a long length of disease in the LAD left main and backfilling of a dominant right. If we didn't have the backfilling, this very likely would have been more than 0.95. So what we had in this particular patient was that the post-PCI physiology helped us identify that the patient still had significant ischemia at the end of the PCI, told us they were missing a focal lesion which needed to be treated, and also told us the stent needs to be optimized. This is another patient who had a bystander disease in the left system from inferior end STEMI. The question is, can we leave that mid-LAD lesion? When we do an IFR pullback, what it tells us is if we have left that or we don't treat it, the post-PCI IFR is very likely going to be less than 0.9. So what we did is we proceeded, put a stent following pre-dilatation in the LAD, put a stent in the left main, optimized the stent, and this is what it looks like after the first round of PCI. But when you do the physiology after this, it's still ischemic, a borderline, but still ischemic and way away from 0.95. And when we look at the pullback, we find it's a diffuse gradient across the stent, but more so in the proximal part of the stent. So what we did, we post-dilated the whole length of the stent, especially the proximal part, made sure with the kissing that this ostium of this LAD stent is well deployed, and we repeated the pullback. Okay, and it's 0.95. So, and this is what it looks like after optimization of the stent. So what post-PCI physiology helped us to do here is tell us that it was still a suboptimal, and all we needed to do to optimize the results was post-dilatation of the stent. Okay, so this is the last patient. Again, a patient with diabetes who was pre-dialysis, has 3-vessel coronary artery disease, tight disease in the intermediate, LAD diagonal bifurcation, and on the right, on the RC as well. We stent the intermediate, we stent the diagonal. In this particular still image, it doesn't show that bad, but there was quite severe ostial pinching depending upon if you looked into the other images. So what we did a detailed physiology of the diagonal here. And what we found is the FFR is borderline negative. The RFR, which is like your IFR in terms of it is a non-hyperemic index, though slightly different technically, that is borderline positive, so discordant results. But however, your CFR is well below 2, and that's driven by a borderline epicardial narrowing and also borderline IMR results, which is close to 25. So based on a low CFR, we decided to go forward and treat the diagonal along with the LAD and in a culotte fashion or a reverse culotte fashion. We went to the right and repeated the physiology in the right. And what we find here is different to what we found in the diagonal. So the FFR is clearly reassuring here, 0.91. However, your CFR is in the gray zone, so it's between 2 and 2.5, and that's because your IMR is elevated in this particular patient with CKD and type 2 diabetes mellitus. So in this particular patient, the post-PCI physiology helped us to identify that we should consider doing PCI to the GL diagonal. It also helped us to identify there's raised microvascular resistance in this particular patient, which helps us to tailor the therapy for this particular patient in the post-PCI setting. So to conclude, 20 to 30% of the patients experience residual angina after PCI. If we do routinely a post-PCI physiology in a big proportion of these patients, we can identify a correctable cause, which is very important. And there's been multiple studies to show that post-PCI physiology consistently improves cardiovascular outcomes and reduces angina burden, and is the reverse if you don't have a successful post-PCI or optimal post-PCI physiological results. So I hope if you're opening up a pressure wire to do physiology, it just makes sense because it costs you nothing more to finish your procedure doing a post-physiology as after the PCI. Thank you.